Welcome again to my series of talks on surgery for undergraduates. Today's topic is an important one titled Upper Gastrointestinal Bleeding, in short UGIB.
I shall now go through a short case history on upper GI bleed. The patient is a 52-year-old man who presented to the emergency department with an episode of vomiting of blood several hours before admission. The patient was apparently well till 2 days ago when he developed epigastric pain, which was relieved with medication. The next day, he vomited blood. The patient has been having mild epigastric pain off and on for the past 3 months, for which he took gastric medication from the GP, but did not go for any investigation. There is no history of stools, passing of black stools or blood in the stools. He is a case of diabetes and hypertension for the past 3 years. He also has some heart problems for which he is taking cardiprine 100 milligrams daily for the last 2 years. He is a smoker and he consumes alcohol occasionally. On examination, he was well. The abdomen was soft with mild tenderness in the epigastric region. There was no guarding and no masses were palpable. The liver and spleen were not palpable and the rest of the abdomen was normal. So in short, we have a 52-year-old man here with one episode of hematemesis, epigastric pain for 3 months, and he's on cardiprine, and he has got tenderness in the epigastric region. So with these findings, we come to a provisional diagnosis of bleeding bleeding erosive gastritis, with the differential diagnosis of bleeding peptic ulcer, esophageal varices, or carcinoma of the stomach.
What is upper gastrointestinal bleeding? This can be defined as the bleeding from any site along the gastrointestinal tract that is above the ligament of Treitz. And the ligament of Treitz is as shown in these diagrams. Okay, this is the ligament of Treitz. It attaches the duodenojejunal flexure to the posterior abdominal wall around the hiatus of the esophagus. This is a clearer view. It shows the second part of the duodenum, third part of the duodenum, and then the fourth part of the duodenum before it becomes the jejunum. And this, known as the duodenojejunal flexure or DJ flexure, is attached by this ligament of Treitz to the posterior abdominal wall. Any bleeding that arises proximal to this ligament, that is from the duodenum, stomach and esophagus, is considered upper GI bleeding, and bleeding arising distal to the ligament of Treitz is considered lower GI bleeding. For practical purposes, upper GI bleeding refers to bleeding from the esophagus, stomach, or duodenum. Before we proceed, we have to look at some definitions regarding this topic. Upper GI bleed, as I said, is proximal bleeding proximal to the ligament of Treitz. Hematemesis is the vomiting of blood, normally of fresh blood or sometimes can be altered blood, which is diagnostic of upper gastrointestinal bleeding. Melena is the passing of the black, tarry or maroon colored stools, which can be due to lower or upper GI bleed, but commonly it's from upper GI bleed. Hematochezia is bright red blood passing per rectum, and this fresh bleeding per rectum is usually a characteristic feature of bleeding from the colon. Okay, what are the causes of upper GI bleed? From the esophagus, these are the common causes: esophagitis, Mallory-Weiss syndrome, esophageal varices, and carcinoma of the esophagus. From the stomach, it can be gastritis, usually known as erosive gastritis, gastric ulcers, gastric carcinoma, and AV malformations in the mucosa of the gastric wall. From the duodenum can be also duodenitis, also considered as erosive duodenitis, duodenal ulcer, duodenal polyps, and duolephoid lesions similar to the one you see AV malformations in the stomach. The incidence of upper GI bleed is shown in this table. Peptic ulceration, which include duodenal and gastric ulceration, accounts for 50% of the cases. Erosions of the stomach, gastritis and duodenitis accounts for 30% of the cases. So peptic ulcer and gastritis or duodenitis together, they contribute to 80% of the cases. The others are divided among the various causes mentioned here. Varices about 5%, reflux esophagitis another 5%, then lesser importance will be Mallory-Weiss tears of the esophagus, carcinoma of the esophagus or stomach, aortoduodenal fistula, and duolephoid lesions. I put another condition here in red to tell you the importance of this problem of coagulopathy that occurs in our population, especially among children, due to dengue fever. Dengue fever is a very common cause of GI bleeding in our country, especially among the pediatric population. So whenever a patient vomits blood or passes fresh blood per rectum, you must consider dengue fever, especially in endemic areas. Another 20% of cases with upper GI bleed, they have no apparent cause on OGDS. Either the bleeding has stopped and minor erosions that caused it have healed. So 20% of cases on endoscopy do not show any signs of or any evidence of bleeding. What are the clinical presentation? First, the symptoms: hematemesis, melena, abdominal pain, drug-induced history, especially non-steroidal anti-inflammatory agents. These are the common symptoms that patients present, and we must take pains to get a detailed history of these symptoms. Then they may also have symptoms of the underlying disease, such as liver cirrhosis. They may have edema, they may have distension of the abdomen, and they may also have jaundice. So these are other features that come along with the diseases that produce the hematemesis. As for the signs, normally they show signs of blood loss, either chronic anemia or shock acute blood loss. Pallor, tachycardia, a heart rate of more than 100 beats per minute, hypotension with systolic pressures less than 100 millimeters of mercury. Epigastric tenderness is another common sign, with or without guarding, is another common sign that is exhibited in patients with bleeding peptic ulcers. And also they may have signs of underlying disease, as I mentioned earlier. Okay, this again is a summary of the signs and symptoms which are very important for you to master. Symptoms and signs of anemia, hematemesis, coffee ground emesis, melena, hematochezia, hypovolemia and impending shock, and non-specific complaints like dyspnea, abdominal cramps, fatigue, and chest pain. What are the investigations that must be done? The most important, as I've highlighted here, is OGDS, esophago-gastroduodenoscopy. Okay, this is the most important and the most useful examination for patients with upper GI bleed. This includes together with it a pyloric test known as CLO test, which is a urease test for the presence of H. pylori, and also a biopsy can be taken, especially if the bleeding comes from the stomach. With the ulcer there, it can be a malignant lesion. Okay, so biopsy is also important, which can be done together with the OGDS. Others include blood tests, which must be routine, especially of special interest is liver function test, to test for the in patients with suspected esophageal varices. And a particularly important blood test is hemoglobin and hematocrit. This may give you an indication of the severity of bleeding. Then there is the urease blood test, which is not done in a bleeding case. It's usually done for patients with chronic epigastric pain. And of course, I want to highlight to you again the importance of OGDS in a patient with upper GI bleeding, the most important diagnosis. It is not only diagnostic in most cases, but also it is therapeutic in many cases of upper GI bleeding. OGDS is done by using a scope, by passing an instrument, like which is shown here, through the mouth of the patient, and we visualize through the use of a camera at the tip of this instrument the mucosa of the esophagus, stomach, and the duodenum. Ulcers, tumors, polyps, and especially bleeding points will be easily detected by this camera system. And this instrument is armed with a few appendages. First is the instrument port through which you can put an instrument to take biopsies, to do washout. Then there is a port for a camera to give you the clear vision for examination. There is a port to introduce air to distend the stomach and the esophagus and duodenum so that you can have better view, and also a light source, a powerful light source, which is mounted at the end of the scope. Okay, this is two views that you can see through the scope. This is a patient with a bleeding ulcer. You see here, there's an active bleeder here, spurting out blood, and a lot of blood in the duodenum. And this is a chronic duodenal ulcer. There's no bleeding, or the bleeding has stopped, and the base of the ulcer is clean. Okay, so this is a normal chronic duodenal ulcer. This is a picture of a varices, esophageal varices at the lower end. You see, these are the columns, engorged and dilated veins, which are known as varices. And on the right here, you see one of these variceal veins fractured, and then you see active bleeding pouring into the esophagus, which can be then vomited out as hematemesis. Now, after confirming the bleeding, you have to assess the severity of the bleeding. And the most important assessment method is clinical. That means getting a good history and doing a proper physical examination. You can assess the patient severity of bleeding. In the history, you want to know the amount of bleeding, the frequency of bleeding, the duration of bleeding. That's very, very important. Secondly, you want to note the color of the bleeder. Okay, color of the vomiters, the blood in the vomiters. Arterial versus venous. Arterial blood tend to be bright red, and the bleeding is more vigorous, and the patient tend to deteriorate much faster than venous bleeding, where the blood is more passive and also it is dark red in color. Associated with this, you look for signs and symptoms of the patient: giddiness, fainting, at times even pre-drowsiness and going into coma. These are all signs or symptoms of severity of bleeding. On examination, the degree of pallor must be noted. It's very important. This is a very important sign to determine the severity of bleeding. The vital signs: blood pressure, systolic pressure less than 100 is a very strong indicator of severe bleeding. Pulse rate and volume is also very important. Heart rate of more than 100 per minute is an indicator of more serious bleeding, especially, and also the pulse volume is very important. Patients with severe bleeding, they tend to have a very small pulse volume, and sometimes the periphery can be cold and clammy. These days we have scoring systems to assess the severity of bleeding, which are quite often used in many centers. and among them is the Glasgow blood spot score, and this is to assess the severity of the bleeding to see the need for intervention. And the second scoring system is known as the Rockall score, which assesses the patient's prognosis after the bleeding and the treatment. Okay, these are two important severity scoring systems. The Glasgow blood spot, which I said, is the screening tool to assess the likelihood that a patient with acute upper GI bleeding will need to have medical surgical intervention like blood transfusion or endoscopic intervention. Whereas a Rockall score is a system which attempts to identify the patients at risk of adverse outcome following acute upper GI bleeding. Okay, it tells you the prognosis of the upper GI bleeding after endoscopy. Okay, this is the blood spot score, which takes into consideration the blood urea nitrogen, hemoglobin level, systolic blood pressure, and other markers like the heart rate, presence of melena, presence of syncope, or comorbid diseases like heart disease and heart failure or liver disease. These are all given a score, and a score of more than 0 is considered abnormal, considered higher than normal risk, and more than 2 is considered more serious risk. The Rockall score is a measure of the prognosis following an acute GI bleed. And the factors that are taken into considerations: age, comorbidity, shock, source of bleeding, and the stigmata of recent bleeding on endoscopy. Again, these are scored individually, and a total score of less than 3 carries good prognosis, whereas a score of more than 8 carries a high risk of mortality. Okay, now we come to the management of upper GI bleeding. This consists of 3 parts: resuscitation, investigation to confirm or detect confirm the source of bleeding, and then definitive treatment. Okay, under the first part, resuscitation, it consists of replacing the blood loss with fluids and blood, okay, and the initial treatment to giving oxygen, high dependency area monitoring of the vital signs, replacing fluids and electrolytes, group and cross-match blood for transfusion, and the indication of transfusion will be severe anemia or patient in shock. Okay, these are important. There are important parameters that you must look into before you decide whether you want to transfuse the patient with blood. And if possible, try to get blood that is fresh, so that all the coagulation factors will be replaced as well. The next is which is often given, is the IV proton pump inhibitors in IV high dose infusion, especially for patients with peptic ulcer, bleeding peptic ulcer. This is not proven to stop the bleeding, but it starts the healing process of the ulcer earlier, therefore makes the bleeding much less and easier to control. Other drugs that have been used are the transamine, tranexaminic acid, which is an antifibrinolytic agent, which makes the blood more coagulable and stop bleeding. And then in patients with jaundice, you may have to give vitamin K to help the coagulation process. And lastly, most important is to do a OGDS, as soon as possible, as an emergency or a semi-emergency procedure to detect the source of bleeding and to offer or institute definitive treatment to stop the bleeding. Okay, this is a summary of the approach to patients with significant upper GI bleed. aggressive fluid resuscitation, routine blood tests including type and cross-matching the blood for intensive monitoring the patient, if possible in ICU with central line monitoring, nasogastric tube, as well as catheter insertion to monitor urine output, blood transfusion if necessary, upper endoscopy to evaluate and treat the cause of bleeding. So the the intensive treatment should end up with the upper endoscopy as soon as possible to detect the source of bleeding. As for the endoscopic maneuvers, it is important. Maybe it's more useful to classify the bleeding either is from varices, variceal bleeding from the esophageal varices, or non-variceal bleeding, which include erosive gastritis and duodenitis. Okay, so these or gastric and duodenal ulcer. So these are the two large groups of patients. So because for further endoscopic treatment or surgical treatment, you have to classify the patient into these two categories. First, the peptic ulcer, treatment of peptic ulcer. Okay, so normally we give them the medical treatment, triple regime, clarithromycin, amoxicillin, and omeprazole. Although there are quite a number of variations to this regime, but these are the common regime which is very widely used and is found to be very compliant among the patients. Then, as for the bleeding ulcer, once the ulcer bleeding has stopped, you have to continue the PPI for 6 to 8 weeks until the ulcer is healed. At times, you may want to repeat the OGDS to confirm, especially in high-risk patients, to confirm the ulcer is healed before stopping the treatment. Then there's something known as maintenance therapy, which is for high-risk patients, elderly patients with heart problems and high-risk medical illnesses. So these patients, if allowed to, the bleeding recurs, they can be very fatal and serious. So as such, you want to cover them with a low dose of maintenance PPI, omeprazole, for maybe for life. These days, we have newer drugs apart from the PPI, which has been the mainstay of treatment. Now we also have new drugs known as the potassium competitive acid blocker, PCAB. And the most commonly used one is vonoprazan, okay, which these are supposed to be more potent, more longer acting, and the effects die off much more early reversal. Okay, these are still in the early stages and not much of studies to confirm their efficacy and their side effects. And I feel this may be the next generation treatment for peptic ulcers and its complications. These newer regimes there's also newer regimes for the eradication of H. pylori, which is now confirmed as the major cause of peptic ulcers and bleeding. Okay, the original treatment is the triple regime which I mentioned to you, which is a 81% eradication rate. Okay, which consists of lansoprazole, amoxicillin, and clarithromycin. Adding another anti-parasitic agent, nitazoxanide or Alenia, to this regime improves or increases the eradication rate of the bacteria to 95%. So this is also something new in the market, and it's a matter of days to see whether it takes over from the triple regime. Okay, next, treatment using endoscopic and surgical methods for bleeding ulcers. First, we have got endoscopic methods. Okay, injection or injection therapy. Okay, we use adrenaline to inject into the ulcer bed. or surrounding the ulcer. These will cause vasoconstriction and reduces the bleeding. Or alternatively, you can ligate the bleeding ulcer. Okay, ligate using, for example, in varices, you can use ligation is a very important this thing. It's called bending. Or you can use diathermy probes. Okay, use diathermy to coagulate these vessels, which stop bleeding. And nowadays, more important has come endoclips, application of endoclips to the bleeding ulcer. And this will also stop the bleeding, at least for the temporarily. And then there are also certain injection of gels, even thermal sprays, and which can cause also vasoconstriction and stop the bleeding. Then for the semi-surgical methods will be underrunning the ulcer. If these fail, the endoscopic methods fail, then you may have to go for open surgery, where you can go and just underrun the ulcer and stop the bleeding. Okay. Then there is the acid reducing operations known as vagotomy and gastrectomy. Okay, these used to be very important and useful operations to stop the bleeding and save life. But with the advent of the PPI and the endoscope's advancements, this is becoming less and less important. Then this can be done either traditionally they were done under open surgery. Nowadays, they can also do it under laparoscopic surgery. Okay, this is a summary of the endoscopic treatment for ulcers. Injection, you can use epinephrine, glue, okay, or you can use sprays, laser to coagulate the artery, the heater probe, monopolar and multipolar, electrocoagulation, clipping, and bending. Okay, these are all endoscopic methods that have been used and are being used to control bleeding from bleeding upper GI. Treatment of esophageal varices. Again, first after the resuscitation, you can add in acute phase, you can give in vasoconstrictors intravenously. Pitocin is a very important one for this purpose, which causes vasoconstriction of the arteries that supply the varices, thereby reducing the bleeding. Then chemical agents or drugs known as somatostatin or octreotide. Okay, these two can be given as infusion, which has got some proven evidence to show they can reduce the bleeding of blood loss. PPI, okay, omeprazole or esomeprazole are important agents to be used. It doesn't stop the bleeding, but it reduces the development of stress ulcers, which cause further bleeding. It also starts the healing process of the ulcer earlier, so that the bleeding has a better chance of being controlled. The next one is to reduce the portal pressure. Why? By reducing the portal pressure, the pressure in the esophageal varices will reduce, and thereby the bleeding will cease. Okay, so this can be done by using beta blockers. Okay, tablets, okay, or IV if in the acute phase, beta blockers, and the most commonly used is propranolol. Okay, which effectively reduces the portal pressure and thereby reducing the bleeding. Then if the chemical methods or the medical methods fail, then you can go into consider surgical methods and the role of portocaval shunts. Okay, so these are the interventional treatment that I was talking about: injection, sclerotherapy, ligation, and clipping of the esophageal varices. Under surgery, you have portocaval shunts, which can be done openly or through the endoscopically. And today's the most commonly used is known as the transjugular intrahepatic portosystemic shunt, TIPS. Okay, this is the most common. So in this portocaval shunt, the blood from the portal system is directly diverted through a shunt into the IVC, or the systemic circulation, and through that the liver, which is fibrotic, is bypassed, thereby reducing the portal pressure and the effective variceal pressure, and therefore the reducing the blood flow. Okay, this is a picture summarizing a transjugular intrahepatic portosystemic shunt, or TIPS, is a tract created, okay, within the liver using X-ray guidance to connect two veins, one a branch of the portal vein and the other one the branch of a inferior vena cava. So there's a graft is applied here, and the blood from the portal veins is diverted into the IVC, bypassing the high pressure zone of the liver. Traditionally, open methods were before the establishment of these endoscopic methods. Open method was to do a bypass between the portal vein and the inferior vena cava, thereby diverting the portal vein blood into the IVC and then back to the heart, okay, bypassing the liver. Okay, this is an algorithm to show you the management of bleeding, upper GI bleeding. Okay, acute upper GI bleeding, patient is resuscitated and subjected to an endoscopy. And this endoscopy will determine whether it's variceal bleeding, non-variceal bleeding, or no obvious cause. Okay, variceal bleeding, as I told you, patient is subjected to sclerotherapy, bending, and ligation. And if the bleeding is controlled, then you will put them on a long-term sclerotherapy or bending program. If the bleeding does not stop, then you have to think of surgical methods, such as TIPS is an important first-line alternative. If it's a peptic ulcer or duodenal ulcer that is causing the bleeding, look at the ulcer, whether look for the major stigmata of recent hemorrhage, stigmata of recent hemorrhage, SRH. If there are positive stigmata, such as a blood clot, active bleeding, or exposed blood vessel and fresh stains of blood, then you know these are considered positive stigmata of recent hemorrhage. So once you have this, then you go for endoscopic treatment. Okay, heat application, injection, or clips. Okay, and the bleeding is controlled, then you reassess the patient endoscopically after 24 hours. If there's no bleeding, then you continue with the treatment, conservative treatment. If there are no major stigmata of recent bleeding, then you continue the conservative treatment of PPI, acid, Helicobacter eradication, and so on. In about 20% of patients, on endoscopy, you do not see any bleeding sites. There's no evidence of recent bleed, and there's no active bleeding. So these patients, when they don't have any obvious cause, if they are minor and stable, continue the conservative management, okay, long-term PPI, and repeat OGDS maybe 6 weeks later. Whereas in patients with major bleed, you cannot wait. So what you do, when you cannot find the source of bleeding, you consider other forms. Okay, see whether you want to do a colonoscopy or angiography to see lower sources of bleeding in the GI tract, such as the small intestine and colon, and treat appropriately. So this chart is a simplified version of the management of acute upper GI bleeding. Now I show you some slides of some bleeding, the endoscopic procedure. You see, this is a duodenal ulcer with an acute bleed. You use a diathermy probe, then you coagulate the blood vessel, and you see after coagulation, the bleeding has stopped. So this is thermal probe or diathermy probe to coagulate the bleeding vessel. This is, you see here on the left side, got a bleeding the ulcer that is bleeding. So you apply clips. Normally you need to apply 3 or 4 clips to successfully stop the bleeding. Okay, these are clips I've applied to ulcer here. Normally, if you cannot apply this to the ulcer, you apply around the periphery. Okay, because the ulcer sometimes is very friable, unable to hold the clip. This is injection. Again, to bleeding, you inject into the peri-ulcer region of the bleeding ulcer, and this adrenaline will cause the blood vessels to constrict and stop the bleeding. And these are clips, endoscopic clips. This is epinephrine or adrenaline injection. Here, these are the various types of clips that can be applied to a bleeding ulcer.
Now we will perform upper endoscopy in a 62-year-old male patient with epigastric pain. First, put the tip of the endoscope on the patient's tongue. Under direct vision, guide the scope through the mouth. You can see the uvula at the 6 o'clock position. When the epiglottis, the cricoarytenoid cartilage, and vocal cords appear, guide the tip of the instrument behind the cricoarytenoid cartilage and instruct the patient to swallow while you apply gentle pressure just to allow the cricopharyngeal sphincter to be passed. Advance the endoscope slowly to allow careful examination of the esophageal contour and mucosa. Examination of the esophagus ends with inspection of the gastroesophageal junction, with its level being determined in relation to the diaphragmatic hiatus. The red mucosal tongues at the gastroesophageal junction are highly suggestive of short Barrett's esophagus. Now advance the scope into the stomach and align the tip along the longitudinal axis of the stomach by means of a 60 to 90 degrees clockwise torquing maneuver. There are certainly many ways of examining the stomach. The important point is to be both systematic and deliberate so as to minimize the amount of unexamined surface area. To this end, our approach in general is to observe the stomach in detail after, rather than before, the duodenum has been examined. So let us first move to the duodenum. The pylorus is examined closely, with particular attention being given to its motility during peristalsis. Now intubate the duodenal bulb by advancing the tip of the scope as closely as possible to the pyloric ring and then applying gentle pressure. At this stage, the patient may experience a little discomfort. Successful intubation results in a red-out appearance due to the tip of the instrument being applied closely to the mucosa of the anterior wall of the bulb. After the proximal bulb has been entered by the pyloric, after examination of the cardia and fundus in retroflexion, return the endoscope tip to the original position in the upper body. Withdraw the endoscope with arc-like movements to examine the upper body and cardia. At the end of the procedure, before you withdraw the instrument from the stomach, Always make sure to aspirate as much air and gastric components as possible to deflate the patient's abdomen. Back in the esophagus, we recommend withdrawing the endoscope slowly to allow, once more, careful inspection on the way out.
Barrett's esophagus is the abnormal transformation of the lower esophageal mucosa from squamous epithelium to columnar epithelium of the intestinal type. The next is a malignant lesion at the lower end of the esophagus, and these are variceal lower end of the varices lower end of the esophagus. Another picture here, severe varices, and again here another varices which is ligated on your right side, post ligation, and this is an actively bleeding esophageal varices. Next we come to superficial erosions of the stomach. This is usually drug induced. And then we have another clean base ulcer, which is usually a benign gastric ulcer. Another benign superficial gastric ulcer. The next one is a ulcer, malignant ulcer of the stomach. And this is a very large ulcer, irregular base, undermined edges, malignant. This is another malignant ulcer. Okay, my talk today on upper GI bleed was a short one, and I hope it would have been of help to you to enhance your understanding of the topic better. Okay, for more of such lectures, you may visit my YouTube channel as given in this link. Thank you and hope to see you again.